Karl Nath, Editor-in-Chief of Mayo Clinic Proceedings, and I am delighted to invite you to view this brief conversation with a featured guest each month in this series, Pioneers and Legends in Medicine. According to Merriam-Webster, a pioneer is one who originates or helps open up a new line of thought or activity or new method or development in their field. In our series, the featured guest represents one whose contribution in a given field of medicine fundamentally advanced our understanding of a particular disease and our management and its treatment. I am especially delighted to introduce our very first guest in these series, Dr. Robert Kyle. Dr. Kyle is a retired consultant in hematology research, a professor of laboratory medicine and pathology and medicine, who has spent some 60 years in the study of hematologic diseases, in particular multiple myeloma. Dr. Kyle is the recipient of the highest individual award bestowed by both the American Society of Hematology and the American Society of Clinical Oncology. In recognition of his many contributions to medicine, the International Myeloma Foundation has established the Robert A. Kyle Lifetime Achievement Award to honor the physician who most exemplifies a singular contribution in the field of multiple myeloma. It is thus my very distinct honor to introduce and to welcome Dr. Kyle. Dr. Kyle, thank you for joining us in this conversation.
It's my pleasure.
Dr. Kyle, I'd like to go back to 1944 to 1946, when your first degree was in forestry. Could you take us through the steps that led you from forestry to a career in medicine?
Actually, the forestry is a bit of a misnomer in that it is actually a junior college and does have forestry as one of its major areas to study in. I was just 16, and neither my parents nor I wanted me to go away to the university at this young age. And so I went to junior college for 2 years. I did not study forestry, but I did work for the U.S. Forest Service the year I got out of high school in 1944 when I was a lookout fireman. I did that for 3 months in the summertime and then returned to school in the fall. Then I continued at the forestry, still in pre-med actually, and then graduated at the end of 2 years and then transferred to the University of North Dakota in Grand Forks.
You did training at the Mayo Clinic in the 50s, and this was followed by a fellowship at Tufts and then at the National Cancer Institute. What was it that attracted you towards hematology following your internal medicine training?
Well, I came here as a fellow in internal medicine. And during the fellowship at that time, you were required to spend 6 months in a laboratory. The third option was hematology. And I said to myself, well, gee, I know less about hematology than anything else. I'll take that. It'll kill 2 birds with 1 stone. It'll do my 6 months of laboratory. And then I will be free to continue on. And furthermore, when I go to California to establish my internal medicine practice, which most people did at that time, I'll have a leg up on the next internist because I'll be able to read peripheral blood smears and bone marrows. So I did. And my project consisted of acquired hemolytic anemia, and I made 2 observations that I thought were pretty decent. One, these patients had a positive Coombs test. Secondly, if you treated them with cortisone, they did better than the patient with lymphoma or chronic lymphocytic leukemia who had a packed bone marrow and had similar degrees of anemia. Well, at that time I could read German fluently, including the script, And I saw a paper that was written by a German hematologist, Pappenheim, as I recall, and he had actually described exactly the same thing I did, and with the same conclusion, except that I had added the Coombs test, which was not discovered until 1950, plus or minus, and cortisone, which was not found until it was found here at the Mayo Clinic in about 1949. So that took a little bit of wind out of the sails of a young guy. And so after I completed the laboratory in hematology, I found that I liked looking at the bone marrows and so forth, but I realized I didn't know anything about clinical hematology. So then I signed up for the 3-month hospital service as a kind of an extra clinical service.
Tell me about getting involved with multiple myeloma and plasma cell disorders.
Yes. On the hematology hospital service, 2 things happened to me that changed my professional life. First of all, I saw an electrophoretic pattern for the first time. This would be in 1958, probably, and I asked the consultant on the service, Dr. Baird, what is this? And he said, well, this is a new test. We don't know much about it, but we do know that there are spikes in the pattern in patients with myeloma or macroglobulinemia. He said, look into it. And so I reviewed the 6,500 and some patterns that had been done since December 1955, when serum protein electrophoresis was first done here as a clinical test, and probably one of the first laboratories in the country to do so. And I came to the conclusion that these spikes indeed were associated with myeloma and Waldenstrom's macroglobulinemia, but there were some that had amyloid and there were some that didn't seem to have anything wrong with them. And so I developed a ratio of 4:1, height versus width. If it was at that level or higher, then it was myeloma or macroglobulinemia. And if it was less, and particularly if it was much less, then this was a broad-based peak and did not amount to anything of importance from a clinical standpoint. And then on that service, I saw a patient who was admitted to the hospital with multiple myeloma and back pain. And at that time, every patient who received radiation therapy was hospitalized. And in going through her record, I noted that her hematologist who had seen her initially had seen that her skin seemed kind of peculiar. He didn't know what it was, and so he sent it to dermatology for a consult. Dermatologist didn't know what it was either, but the dermatologist has an obvious advantage on us in that he or she can do a punch biopsy. Punch biopsy was done and was reported a day before she was admitted to the hospital, and it said amyloid. And I said to myself, amyloid? What in the world is that? And all I could think of was back in sophomore pathology in medical school of this glassy looking material that had no cellular features. In 4 years of medical school, a year of rotating internship, 4 years of internal medicine at the Mayo Clinic, and 2 years in the Air Force in a 400-bed hospital, I had never recognized a case of amyloidosis. And so this was rather unusual, so I went to the medical index and found 80 cases or so that fulfilled the criteria for AL, or for primary amyloidosis. AL was not recognized at that time, of course. And these two experiences put me in the field of plasmacytic disorders. I felt in my heart that I wanted more training. So I made a visit to St. Louis, to Washington University, where Karl Nath, a very well-known hematologist, was at, the University of Rochester, and Boston, where Dr. William Damashek was. I visited each of the three institutions, and the position, the first two positions were too localized in the laboratory. One was on iron metabolism with Dr. Moore, and Dr. Damashek, however, was a very complete hematologist in my mind, and had a private practice in addition to his academic duties. The only person at the hospital who had that opportunity. And so I accepted that, and he obtained actually a postdoctoral research fellowship for me from the NIH. And that's how that turns up in my CV.
One of the many impressive things about looking at your CV is your steadfast, unwavering dedication to a particular disease, multiple myeloma. What are the facets of the disease that have kept your attention for close to 60 years?
Well, the first thing is that one can measure a certain aspect of the disease in the laboratory. And when I came back as a hematologist, but the vast majority of one's practice was general internal medicine. And one did off the floors, and I was still particularly interested in the myeloma amyloid because of the papers that I had published. And so the laboratory did not do electrophoresis and immunoelectrophoresis, and I realized that this was an absolutely essential thing that had to be done. So I talked to our division, and my colleagues were all in favor of this, and so I wrote a letter, and it was supplemented by the section heads, and I didn't hear anything for a while, so I kept rewriting. After 14 months, the head of internal medicine, we did have an internal medicine by that time, Dick Reidemeyer, and a head of laboratory medicine, Gene Mayberry. And they invited me in and said, we will give you 2 hours a day to set up this laboratory. So I always had a little laboratory base for this. And I continued to write and publish in both the laboratory area of recognition of the monoclonal proteins, as well as the clinical aspects of the importance of monoclonal proteins. And I made it a practice to call every consultant who had who had ordered a serum protein electrophoresis and had a spike or a monoclonal protein in it that was recognized by this time. Basically, Karl, it was just very interesting and very fascinating. And by calling the clinician, I learned a lot about the importance of monoclonal gammopathy and so forth.
You know, Dr. Karl, the first time I heard your name was in the early 80s at the University of Minnesota in regards to a paper you wrote on monoclonal gammopathies of undetermined significance. You've really, among the many things you've done in myeloma, you've pioneered that whole area. Could you take us through the development of your thoughts in terms of the boundaries between mothers and smoldering myeloma? And is it just a matter of time before the undetermined aspect declares its significance?
Well, in a single word, yes.
Yeah.
But this is a little bit more complicated. And again, I emphasize that this thought came to me in seeing a patient that I saw with multiple myeloma in 1964. This woman had full-blown multiple myeloma, back pain, lytic bone lesions, large M spike, large number of plasma cells in the bone marrow. Full-blown multiple myeloma requiring therapy. And I wrote a prescription for one of the two drugs that were available at that time. But I happened to notice, and this is a credit to the record system at the Mayo Clinic, in the back of the history was the previous visits of the patient. The patient had been here in 1945, almost 20 years before, complaining of fatigue. The internist who saw her ordered a sedimentation rate as a kind of a screening test, and lo and behold, the sed rate was above 90 millimeters per hour, which gets any internist's attention. And he then ordered an AG ratio. The internist very wisely patted the woman on the shoulder. Her hemoglobin was okay. Her blood urea, which was the test used for renal function at that time. Creatinine was yet to come. Karl, believe it or not. and so sent her home with no treatment. The patient came back 13 years later, at which time she had serum protein electrophoresis, and she did have a large monoclonal protein in the serum. But everything else was normal, and the physician who saw her very wisely patted her on the shoulder again and said, "Things are fine, go about your business." And then it was probably 6 or 8 months before she appeared in 1964 when she developed the back pain and subsequently the diagnosis of myeloma. And so that seemed kind of peculiar. So I kept my eyes open for that and began to recognize other patients because I was getting access to the laboratory and learning that there were some of these patients who had a monoclonal spike. They didn't seem to have anything else and seemed to be getting along pretty well. So then I started collecting these patients. So I collected these 241 cases, submitted it to the Green Journal at that time, the American Journal of Medicine. This was monoclonal gammopathy of undetermined significance.
Could I ask you to reflect on what's really a national concern, i.e. there are all of these statistics saying that there is increasing dissatisfaction by physicians and their careers, and the whole phenomenon of physician burnout is something that is being addressed almost at not only a regional but a national level. You've maintained this remarkable freshness, enthusiasm, drive, and achievement for close to 60 years. How did you preserve that tremendous enthusiasm in a profession that is in some way troubled by more bureaucratic demands, more, if you will, paperwork, more crossing the T's and dotting the I's rather than direct patient care? Could you share your thoughts on what was your success story or how you achieved it?
Well, first of all, I'm interested in people, and I like to know where people are from. I also like to know what people do and what their occupation is, what their interest is, and then I remember those people by and large, and I inherited this from my mother.
Yeah.
She knew everybody and knew everything about them, and I've always had that curiosity. Same thing with patients.
Yeah.
And you learn from the patient, and you talk to them, and something comes up that is different. And when it comes to the young people, I always emphasize to them to listen to their patient and to think about that particular patient a little bit, and if they have an idea about it, to pursue it and to look into it a little bit more. Why? This way, just simple things. So you have to kind of keep an eye, and you have to look at that individual patient and follow them along. And the young people, you encourage them to write.
Dr. Karl, you've got amazing interests outside medicine. You're an expert in stamp and stamp collecting. Could you share some of your thoughts about how that hobby and interest arose?
And I'd had a passing interest in stamps, and I also knew that there were stamps that were published relating to particular diseases. One of the editors of JAMA called me and said that he was a stamp collector, and that a person at JAMA had written a number of stamp vignettes on persons who had been depicted on postage stamps. He, Dr. Feit, wanted to know if I would be willing to go over these vignettes and check them for accuracy and perhaps to add to some of them. And so I scratched my head and said, well, yes, I'd be interested in that. And so the editor of JAMA asked me to continue writing new vignettes. And so for about 20 years, we published these vignettes in JAMA. And so then I went to the editor of Proceedings, or Mayo Clinic Proceedings. We used to call it Proceedings all the time. And then they were interested, and so it's been published in Proceedings to this day.
Dr. Karl, this has been an absolute delight, pleasure, and an honor for me to interview on behalf of the Mayo Clinic Proceedings. It truly is an honor for me as well to say I'm one of your colleagues at Mayo Clinic. Your contributions in the field of myeloma and related disorders are truly legendary. And on behalf of the Proceedings and all our staff, I'd like to thank you for this phenomenal opportunity and privilege to sit and talk to you about your career and your guidance and your wisdom to read our audience.
Well, thank you very much, Karl. I'm very pleased to do it.
We hope you found this presentation from the content of Mayo Clinic Proceedings valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you will find access information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.